Well, thank you for guys coming out again. So just to go over quickly what I just said earlier, we're going to talk a little bit about the past, present, and future of deep brain stimulation. The past, a little bit about some of the origins of how we started using electricity for actually medical therapy. Dr. Lising will then take over and talk about how deep brain stimulation, the indications now, the good and the bad, as well as really talk about some of the questions you should be asking yourself as well as your neurologist. And then we'll talk about the future new research, the upcoming changes that we have in the pipeline for deep brain stimulation. So let's talk about first the past. So the past. For me, I've always been interested in history. I've always found it fascinating how what we have today, the technological advances that are available to us, to be able to have such great implications to people's lives. I've always really appreciated the amazing clinicians and neuroscientists that came before us and really want to acknowledge the road they paved for us, as well as really be able to appreciate these benefits they have given us. In addition to that, not only are their stories inspiring, I've also really appreciated about learning the mistakes they have done so that we can continue to move forward, use what they have learned and move forward into the field. So let's start off with some of the history. So the history, actually, using electricity in medical therapy is not really a new idea. The first time it was ever thought was actually in 46 AD. So Dr. Lago was actually the physician for the Roman emperor at that time. He realized that when people touched an electric ray, they would have an intermittent insensitivity to pain and kind of numbness. So what he did is that he would put these electric rays on people's heads, and that's how he treated headaches. And so as you can imagine, we have definitely gone a long way from then. That is not our gold standard of treatment for headaches now. But the idea of electricity definitely went on in history. In the 1200s, it was actually using catfish for actually seizures. The thought was that it reset the brain and actually helped it regain its normal activity. In addition to that, in the 1800s was actually when we really started using animals, and we started realizing when we electrified a certain part of the brain, it would twitch a certain part of our body. But however, it wasn't until the 1950s that Dr. Penfield, one of the famous neurosurgeons, decided to do that actually to the human cortex. What he realized is what he was mapping out the brain function. In other words, he would electrify a certain area and it would twitch the left leg. He will electrify certain on this side and it will move the right arm. So this mapping that he actually figured out is what we still use today in terms of the brain function. Now in the 1930s and 1950s, actually we started using electricity by just putting it on top of the skull, and we realized when we did these certain therapies, it actually really helped with psychosis and pain. But up to this point, however, electrotherapy was quite widespread, a little bit random. It was just kind of put it on your head and kind of hope for the best. It wasn't until, however, Dr. Jose Delgado wanted to do something different. So Dr. Delgado was a really famous Spanish neuroscientist. What he wanted to do was figure out a way to really pinpoint that electropulse, put it into a specific part of the brain, and see if he can alter motor movement. So what he wanted to do, he took electrodes, put it into a bull, a brain of a bull, and then what he could do is he could activate current through an external remote control. So through this external remote control, he felt that he could actually give a certain electrical impulse into the bull's brain and actually either abrupt or stop a charging bull in its tracks. So this is what he discovered at that time.
Electronic mind control research is not new. A scientific milestone in this area came in the 1960s when Dr. Jose Delgado demonstrated remote control over a charging bull. By connecting a radio antenna to electrodes inserted into the bull's brain, Delgado proved that the animal's aggressive impulses could be thwarted by electronically manipulating the bull's muscle reflexes.
Do you realize the fantastic possibilities if from the outside we could
so you can see the bull is quite confused, I'm sure. He's trying to charge for that red cape and can't. So what you can see is he realized he could actually control motor movement. He figured out where in the brain you can actually impulse and change the movement. So during this time, we started realizing, well, what other things can we do? What other movements are unwanted that maybe we can stimulate or take out and maybe can improve other types of diseases? So in the 1950s and 1990s, it was found that there was a certain area of the brain called the globus pallidus as well as the thalamus, and it was thought that if we heated it or ablated it, it would actually improve Parkinsonian symptoms. Now, at that time, we would take out those sections of the brain, but people actually in general, even though their symptoms got better, their tremors and their slowness, they weren't tolerating this procedure very well. They were getting really bad speech-swallow issues, cognition issues. And so that is really how deep brain stimulation emerged. It was thought that, well, we know where to go, but let's, instead of ablating it, let's use electricity and see if we can modulate, if we can regain that balance in those damaged neural circuits. And so what we'll do today is I hope you have a little bit of a history of knowing what can be used in the past for medical therapy. However, at this time, we're actually looking much more forward to what DBS can do in the present time.
So now I'll discuss DBS now, and more importantly, how it pertains to you as a patient. So let me start by asking first in the audience, with those who feel comfortable sharing, does anyone here have DBS or know of someone who has had DBS surgery? If you can raise your hands. Great, great. So some people here. And is there anyone here who has never heard about DBS? Great, great. So welcome. And we're hoping at the end of this talk, you'd feel a little more comfortable with what deep brain stimulation therapy is and how it can help patients with Parkinson's disease. So quickly, just an overview. Like Dr. Yang had discussed earlier, we're going to talk about the present, discuss when it's time to be evaluated for DBS, what DBS is and how it works, inclusion criteria for DBS, the DBS candidacy process, and what to expect after surgery, and go over some of the data in long-term outcomes. So just a little bit about Parkinson's disease. It's a relatively common chronic neurologic disease, which affects 1 out of 100 patients over the age of 80. And the prevalence actually increases up to 4% for people above the age of 80. So approximately 60% or 60,000 newly diagnosed cases per year occur here in the US alone. So the exact cause of Parkinson's disease is actually unknown, but we know that genetics and environment play a role. We know that there are cardinal symptoms of Parkinson's disease depicted here in this picture, mainly bradykinesia, with or without tremor, and rigidity or slowness, bradykinesia meaning slowness, and then rigidity meaning stiffness, and then postural instability. There's no objective tests to kind of diagnose someone with Parkinson's disease. It's a clinical diagnosis. And oftentimes, patients who have these symptoms will go to multiple physicians before they actually get diagnosed, and are oftentimes referred to a center like ours to get evaluated by a movement disorder specialist. And what we do know about Parkinson's disease is that it's due to a loss of dopamine cells that basically help control movement. So in terms of the medication that's used, we have plenty of medications that help modulate the dopamine circuit. So why would we consider surgery at all? So we know that the disease, for Parkinson's disease in general, progresses, and that within years, despite working with your neurologist and taking medications, that the medications start to wear off and you may develop dyskinesias. So to just describe this chart here basically is time, and the y-axis is basically the degree of disability. So as you can see, at the time of early Parkinson's is when you develop the motor symptoms of Parkinson's that I described earlier. And with time, the disability increases, and patients will start developing fluctuations in their symptoms and possibly dyskinesias, which I'll go into further. So this picture here kind of depicts where we are in the state of treating Parkinson's disease with medications. We know that medications at a certain point may not be able to control the symptoms to the patient's satisfaction. They may develop more hours of off time during the day. Patients may start having some longer wait times for the medication to kick in, wearing off of the medication again between doses, needing to take it more often, and then the drug-induced side effects of having uncontrolled movements. And it is at that point that you start actually thinking about DBS. So some questions to ask yourself. If you are a patient with Parkinson's, or if you're a Parkinson's disease patient. So do you experience periods when the medication is not helping enough, or that you're experiencing your Parkinson's symptoms? Do you have excessive troubling dyskinesias? And these are these involuntary excessive movements. Do you take frequent doses of dopaminergic medications in a typical day? And despite having tried several drug combinations, do you experience any of the following troubling side effects? Mainly sleepiness, nausea, lightheadedness upon standing, personality or behavioral changes. If you answer yes to many of these questions, that's when you want to start thinking about deep brain stimulation. So deep brain stimulation is an FDA-approved procedure, and more than 100,000 people worldwide have had this done. It is a brain surgery, and what it is actually a small pacemaker-like implantable device that sends electrical signals to the motor area of the brain that controls movement. So these signals basically block the brain messages that cause the disabling motor symptoms of Parkinson's. In the past, the way they used to do the surgery was actually make a hole in the brain. They would make a lesion in the area that they believe is involved in the motor circuit, and this is actually destroying the tissue and is irreversible. So with DBS, it's considered a reversible procedure where you don't make a hole in the brain, you don't destroy tissue, and a procedure that is actually allows you to modulate therapy and improve symptoms. So the right time to think about DBS is when the body stops responding to medications as well as it used to, and before the medication stops working completely. So the thing to remember is that it's not a cure for Parkinson's disease, and it won't change the progression of the disease, but it will improve the motor symptoms of Parkinson's and improve your quality of life. So if you wait too long, there is a time where that window will close and DBS therapy will not be an option. So the basics of DBS. So as I mentioned, it is basically like a pacemaker for the brain. And you have these leads that go into the brain that have 4 main contacts or electrodes that can be stimulated. And here they would be labeled 0, 1, 2, 3. And there's lots of variables that can be adjusted, including the voltage, how much energy you put into through the system, the pulse width, and the rate and frequency. So this is just to give you a brief overview of how the stimulation can be tailored to the patient's symptoms. So how does DBS therapy work? We don't know. What we do know is that in Parkinson's disease, there is this excessive abnormal pattern activity in the brain. And for some reason, when you stimulate that, it basically takes that abnormal activity and allows the cells to communicate more freely, and therefore lessen your symptoms of Parkinson's. So in terms of the inclusion criteria for DBS, you have to, first of all, have Parkinson's disease. Some people with Parkinsonism who don't necessarily have Parkinson's disease or have an atypical Parkinsonism don't usually respond to DBS. So we like to make sure that patients, one way to assure this is that we make sure patients are levodopa responsive, that they've had an adequate trial of the appropriate medications before we decide to do this elective surgery. We know that DBS can also worsen depression and dementia, so we look for absence of these severe mood disorders or depression or dementia. And we also see that there is we also check to make sure that there is a significant degree of disability, that their motor symptoms of Parkinson's are affecting their activities of daily life. And then also in terms of surgical risk, we look to make sure that there isn't significant comorbidities that will just increase their risk for the surgery. Some exceptions, though, are tremor and severe dyskinesias. If these are significant symptoms of the patient, and they are not as, for example, for tremor, if they're not levodopa responsive, deep brain stimulation will tend to always get rid of tremor. So questions to ask your neurologist is to ask them to go over what symptoms will get better. So these will, in general, be the symptoms of Parkinson's, which are rigidity, slowness, freezing, and shuffling, if these are symptoms that get better with Sinemet. We also tend to tell patients that tremor will improve and dyskinesia will improve, along with the motor fluctuations and wearing off. So what symptoms will not be affected or can get worse with DBS? And these are what we kind of title the axial symptoms. In general, if you think axial or midline, so your speech or your swallow, balance or postural instability, and then this on-medication freezing of gait. So freezing of gait is a specific phenomenon in Parkinson's disease where patients kind of feel that their feet are stuck to the ground, which in general can respond to Sinemet. But if you have these symptoms in the on state, they are less likely to respond to deep brain stimulation. And then again, the non-motor symptoms of Parkinson's disease are less responsive to deep brain stimulation. These include things such as constipation, drooling, fatigue, mood and memory, sleep disturbances, and urinary complaints. Another thing to review with your neurologist if you're considering deep brain stimulation is the risk of DBS. So clinical experience and formal studies have kind of quoted an infection risk of about 3 to 4% in terms of perioperative and delayed infections. This increases with certain comorbidities such as diabetes or people who are on steroids. And it's a real risk, so something that you should definitely review with your neurologist. There's also a risk of hemorrhage. We quote about 1 to 2% risk of hemorrhage. And the things that will increase this risk are high blood pressure, shrinkage of the brain or atrophy, diabetes, and in general age. And then worsening cognition. So patients who may have some cognitive impairment, which is very common, commonly seen as a non-motor symptoms in Parkinson's, are at risk of developing maybe postoperative delirium and just change in cognition or worsening cognition with the surgery itself. So in terms of DBS evaluations, it's pretty much standardized across all movement disorder centers. But I'll go over how it's done here at Stanford. First, you will meet with a neurologist, and this is our growing and large team here at Stanford. And oftentimes, the neurologist will do the initial evaluation, confirm diagnosis, educate the patient on DBS, and just make sure to take a careful history of the symptoms and what the patient's goals are, and make sure that the patient's medications are optimized, and that they have a significant disability that can be improved with DBS. The next step would be to schedule an on-off test. And this basically is having the patient come in the off state, meaning off all their medications and therefore with their Parkinsonian symptoms. And what we look for is basically the levodopa responsiveness. So we have patients come in the off state, and then the next day we have them come in the on state, and we look for basically at least a 30% improvement to justify doing this elective brain surgery. And the next step is neuropsychological testing, where we have this extensive battery trying to characterize any deficits in cognition or mood that can help us better determine if a patient is a good DBS candidate. And then here we actually discuss all our patients who come through our program with our DBS review board. And it's a multidisciplinary review board with our neurologists, our surgeons, and our neuropsychologists. And we basically from the videotape that we had done during your on-off testing, we kind of project that and we all discuss and come to a consensus of whether or not this patient would be an ideal candidate for DBS and to do what's best for the patient. And typically you meet with the neurosurgeon afterwards, and we have our two great neurosurgeons here, and you get scheduled for surgery. So this process is an extensive process, and it can take up to a few weeks to months for it to all be completed. So in terms of the DBS surgery, I'll just briefly review the process and kind of what to expect. So the technique that we do here at Stanford is unique in that we do a frameless type of surgery without the traditional frame. And this is something that the patients have expressed as a preference because it allows them to be a little more mobile during the actual surgery. And we do the type of surgery we do here is awake stereotactic. So meaning that the patient will be awake during the surgery, a portion of the surgery, not the whole surgery, but a portion of the surgery to kind of be involved in the mapping of the brain to ensure that we're in the right place. So the day before surgery, patients usually come in and they get these little fiducial markers placed on their skull. And these are kind of landmarks to allow our system to localize where we are going into the brain the day of surgery. You're able to go home that night, the day before surgery, and you come the next morning and you get a CT scan done just to make sure that all the structures are in place and to allow us for more precise targeting of the nucleus that we're targeting for the surgery. And then you're put under full anesthesia for this portion, and then the burr holes are placed. And these are basically a surgery where they drill holes in the skull. And after that, you are awakened for the awake portion of the surgery. And at this point, patients don't feel pain because the brain does not have any pain sensors. And this is the part where the patients participate in the actual mapping of the brain. And what we do is we take a micro electrode drive and a stylus that we basically kind of drive through the brain, and we listen to the different sounds and signatures of the brain to localize where we are, and kind of verify that we're in the appropriate nucleus. At that time, we have the patient participate in kind of doing movements in the OR, operating room, and we also stimulate to make sure that they get the benefit that we want and don't have significant side effects. And then after that, the patients are put under anesthesia, and the surgery is complete. They come the following week to get the actual battery placed. So I wanted to share a case of one of my favorite patients who got deep brain stimulation, just to show you how effective this therapy can be. So this is him in the pre-op evaluation. As you can see, he has a lot of tremor. Asymmetric, worse on his left side there. Tremor in the leg as well. He has the bradykinesia, or the slowness in finger tapping, as you can see. And he also has a lot of rigidity, which you'll appreciate in the walking. And then here is his post-operative video, and he's wearing the same thing, but it is post-operative after DBS. And you can see he's very happy. And we're just talking. He's just letting us know about his experience with the surgery. And you can see the tremor is basically resolved with the DBS stimulation. And this is actually him off meds. We usually do the post-op evaluation off meds on DBS. And he's much faster with walking. The bradykinesia has also improved. So what happens after DBS? Many times we can actually lower medications as we increase the voltage of the stimulation. And patients can decrease their frequency of dosing and the amount of medications that they take. In addition, in terms of long-term improvement after DBS, so several studies have shown that patients have sustained improvement up to 5 to 6 years post-surgery. One study has shown that beyond 9 years, patients have had improved overall symptomatic treatment in terms of their tremor, their gait, up to 42%. The one thing that this study did show was that posture didn't improve at 9 years out of surgery. And this just kind of corroborates the fact that postural instability is just a marker of basically the disease progressing and just one of the symptoms that are hard to treat in general with Parkinson's disease and deep brain stimulation. So as you can see, DBS is effective, but there's always more on the horizon.
But what we'll do right now, we're going to talk a little bit about the future and some of the things that actually are in the upcoming in terms of new ways to actually make the DBS a little bit more effective. So right now, actually, in 2013, DBS celebrated its 25th birthday, so it's actually done over 100,000 in the US. But even with that, we still have many advances that are still on its way. So number one actually is the battery. So the battery is about this big, and it is placed on your chest. Now from the outside, it is visible. It's under the skin, but it is visible. In addition to that, it does need to be changed about every 3 or 5 years for now. Now changing the battery is a relatively simple procedure. You go in for the day, you come out that same day, no overnight or anything. Really simple outpatient procedure, but still has to be done about every 3 to 5 years. In the future, what we're hoping is that there's always going to be new generations of batteries in the next several years. They'll get smaller over time. In addition to that, hopefully they'll be even small enough that it doesn't have to be in the chest, but actually in the head, so it wouldn't even be visible anymore. In addition to that, we're hoping that the new generation of batteries will also last up to 25 years, so much more convenient than the 3 to 5. In addition to that, another thing that's always been a problem actually is MRI compatibility with the DBS. So as of 3 months ago, before that, it was always said that after you have the DBS, you can never have an MRI from the neck down. Now you can imagine that's a really big problem. Knee problems, shoulder problems, back problems, very common things. So that's always been a problem for a long time. Now as of about 2 or 3 months ago, the head, MRI head, however, is okay under certain circumstances. So that's always been okay. But definitely the shoulder down is not okay. Now, as of 3 months ago, however, the new generation batteries that are available right now was just announced that it is MRI compatible, but there has to be certain conditions. So for example, the DBS has to be turned off. The MRI has to be a lower magnet power. So, there's things a little bit now that we have to adjust for, but in general, actually, it is MRI compatible, which is a new thing that has been going on. Hopefully, as several years or decades may be coming up, the battery will become even more convenient, where you don't have to do different things to the MRI and different things to the DBS. In addition to that, remote care and monitoring of the unit. So right now, the DBS programming looks something like this. So basically what happens every time you see the physician will do its little computing programming and will adjust the stimulation over here. What happens usually is that this part goes over the DBS, and this is how we program. Now, over time, we're hoping that this will become wireless. So that will be one convenient thing. In addition to that, there is a patient programmer that is available that we use now, and the patient programmer allows you to actually program a little bit at home on your own. For example, let's say that you have a little bit more tremor because you have a performance coming up. You actually could theoretically increase your stimulation a little bit for that performance and go back down afterwards. Now that patient program is a smaller version of what we just saw that also has a little wire that you have to use it, but hopefully over time that will become wireless as well. Another part of it that we're hoping will come up is the monitoring of the units. Well, we're hoping one day in the future there will be actually markers in your brain that right now the DBS, all it can do is put in electricity. What it does not do right now is tell us what your brain is doing. One day we're hoping that actually the DBS will be able to know when you're tremoring, and we can actually use that information at the clinic as well. Other things that we're looking forward to is actually there's different kinds of electrodes being made right now. So the electrode that we have now looks something like this. So this goes into your brain. Now when we turn it on, there is a field, a very circular field that we use in order to increase the stimulation and improve your tremor. Now you can imagine if one side could actually be the therapeutic side, this is the tremor side. The problem becomes if this other side actually is the one causing side effects, causing unwanted twitching somewhere, unwanted numbness. What we're hoping actually with the new types of electrodes that are coming out, we will be able to control the shape of the electricity. So this will not only improve the therapy, the therapeutic effects of the DBS, but actually it would also decrease the side effects as well. Other things we're really looking for, so this is very exciting. So right now, the DBS, how it works is that every time you come to the office, we program it. We program what the DBS, what to do, and it gives the electricity in the brain at a constant rate. It doesn't really change. Overall, however, over time, what we're hoping is that we're going to have DBSs that will eventually know when you're tremoring. It will know when you're tremoring, and actually on its own, it will increase the stimulation on its own and actually start programming itself. And you can imagine that is actually much more beneficial. Right now, as most of you know, Parkinson's symptoms are not static. They change all the time. And so it's almost like a moving target, what we're trying to do, but this will help with that variability. In addition to that, and this is, I think, the most exciting part of DBS, DBS right now has largely been for Parkinson patients, but actually slowly we're realizing that it can be used for other medical problems as well. There's research being done in chronic pain, depression, obsessive compulsive disorder, as well as epilepsy, and even, and I think this is interesting, obesity. So it's really interesting and really just exciting to see how much DBS has grown and how much more implications it can have for future patients. And the last thing, so this one I think is really fascinating, that there are many different ways that we can connect the brain to actually different kinds of electronic devices. So Dr. Jeffrey Lim is actually a vet, and he is a neurologist. He's critical care trained in Johns Hopkins. What he wanted to do is he wanted to create some kind of sensor, put it on the brain, and somehow connect that to an external, for example, robotic arm. So what he did was that he really wanted to take advantage of all we knew about, remember, the brain mapping, knowing exactly where the arm will be, and use that to actually different ways of controlling outside devices. So what I'm going to show you now actually is a video of Jan. Now, Jan, I guarantee you, you're going to love her because she is quite an amazing person. And the reason why is that when she turned 50, around in her 50s, she realized she was having weakness in her arms and legs. She was actually developing at the time a disease called spinocerebellar degeneration. Basically, her spinal cord was degenerating. By the time of 5 to 10 years, she actually became quadriplegic in her 60s. So very, very sad, but at the same time, Dr. Jeffrey Lim wanted to do something for her. So what he did was that he created these specialized sensory cursors, put them onto the top of the area where the arm is, and connected that to a robotic arm. Now Jan actually is able to control this arm simply by thinking. So let me show you.
Herman put herself on the line for a more sophisticated version of the surgery that they had done earlier in the monkeys.
There's a brain surgery involved. It's experimental. Why were you so excited about it?
I've always believed there's a purpose to my illness. I didn't think I would ever find out what it was in my lifetime. And here came this study where they needed me. You know, they couldn't just pick any Tom, Dick, or Harry off the street. And in a few years, the quadriplegics and the amputees, it's just going to help. The Department of Defense is funding some of it for the vets. To be of use to them and service to them, what an honor.
What I'm going to do right now is I'm just making some marks here in your hair.
The procedure was done by University of Pittsburgh neurosurgeon Elizabeth Tyler Kabara, who showed us that the area that controls hand and arm movement is accessible right on the surface of the brain.
What are the dangers?
We worry about if we were to accidentally tear a blood vessel while we were putting them in, that we could cause a blood clot that would collect on the surface of the brain. probably the thing we worry about the most is the possibility of infection.
I mean, you do have a connection through the skull to the outside world.
Absolutely.
May I have some irrigation?
During the 6-hour surgery, 2 sensor arrays, each the size of a pea, were placed on the surface of Jan's brain.
Woohoo!
Then they were wired to 2 computer connections called pedestals, the gateways to Jan's thoughts.
You know, people are going to look at those pedestals in your skull and they're going to think, that has to hurt. Is it painful? Has it been difficult in any way?
For a few hours after I woke up, I had the worst case of buyer's remorse. I was thinking, oh my God, I had brain surgery. Why didn't anyone stop me? Why didn't they say, Jan, you're crazy? But as soon as the headache went away, that kind of talk went away too.
5 months after the surgery, we came back to see whether she would be able to control the robotic arm with nothing but her thoughts. They plugged her brain into the computer, and this is what we saw.
I can move it up and straight down and left and right and diagonally. I can close it and open it, and I can go forward and back.
That is just the most astounding thing I've ever seen. Can we shake hands?
Sure.
No, really.
Yeah.
Like, come right over here?
Yes, you come over
Okay.
there. Let me grasp your hand there. There we go.
Oh, my goodness. Wow.
And I can do a fist bump if you'd like.
That's amazing. What are you doing, Jan? What's going on in your mind as you're moving this arm around? What are you thinking?
Okay, the best way to explain it is raise your arm.
Uh-huh.
Go. Now,
Right.
what did you think about when you did that?
Well, not very much. I do it all the time.
Exactly. It's automatic.
Is that hard work? Are you having to concentrate?
No, it was hard work getting there. I struggled greatly.
So as you can see, it is such an amazing time to be in neurology right now. We have the technological advances to really combine what we know about brain function into the clinical practice. And we're making these discoveries all the time. We're having more different kinds of medications, different kinds of surgical options for Parkinson's disease, and we look forward to learning more. And so at this time, I really hope you're able to take home a couple of things. Number one, a little bit about the history, appreciating how far we've gone even in the last several centuries, and actually even the last 3 decades after we started using DBS. Some of the future stuff that's coming up as well. I hope you're able to learn a little bit more about DBS, some of the indications, some of the bad and the good. But really importantly is knowing what are the questions you should be asking yourself, your family, as well as your neurologist. And that's also another important point. The decision to do DBS or not is very much a family decision. Everyone is affected by this. And so that what you all are doing right now is perfect, learning about what's available and doing it as a team. In addition to that, what's also very important is know what the resources are available to you. So one, of course, your primary neurologist, of course, us at the Movement Disorder Department, but also what we have is actually, we do have a DBS monthly informational session. So we actually do have these sessions run by our neural surgeons. Actually, it's run by one of their nurses. And that is another place you can actually really sit down and talk about your specific questions. And so what we've done also today, there's a bunch of flyers that will be outside here. We're going to have mini gifts for you. So number one, there's also going to be a flyer of just basically everything that Dr. Lising talked about, kind of a nice packet, the bad and the good, and the questions to ask your neurologist. We have here also the informational session with Carlos. Carlos is our nurse with the neurosurgery. And last but not least, a DVD. Of course, DVD or video, basically the stuff about DBS as well. So I hope you're able to learn a little bit today. As usual, on behalf of the Stanford Department in Neurology and Movement Disorder, we're very happy to be here. Dr. Lising and I are very excited to be part of this field and very honored to be part of this community. And we're here to help in any way we can. Thank you so much. Fantastic. So what we'll do, I guess, Dr. Lising and I will. Sure. Thank you.
Sure.
Great. Go right ahead.
Well, I came here with an essential tremor, and I see that you're mostly focusing on Parkinson's. Does what you're doing apply to essential tremor patients as well?
Sure, yes. So the question was, does what we discussed here today regarding DBS also apply to essential tremor? The therapy itself, the deep brain stimulation, can also help essential tremor. That's actually the first indication that the FDA approved the DBS for, was back in 1996, I believe, or 97, is when they found that it can help essential tremor. So in terms of the criteria for for being a good DBS candidate, it's a little different, but we go through the same process with our program here. We have you meet the neurologist, we evaluate your baseline tremor symptoms, you typically off medications, and then we have you also do neuropsych testing if we see any concern about your cognition, and then have you meet with the neurosurgeon. And it's pretty much the same process, but of course different disease. But it can actually have as good benefit with tremor. It's actually one of the most rewarding things to see in the operating room, because we see the tremor go away immediately when we stimulate.
Great.
So transcranial magnetic stimulation wouldn't work because it couldn't be located closely enough to the problem?
That's correct. So the So TMS, which is transmagnetic stimulation, whether that would be one way to provide the electrical impulses in order to help with Parkinson's disease. So right now, the location that we use is actually really deep into the brain. So the location actually would be theoretically too superficial. Now, of course, there's many different kinds of research being out there trying to see if maybe it can help a little bit or halfway, that kind of thing. But as of right now, TMS is not what we use for Parkinson's symptoms. Yes, go right ahead.
I just want to check that I got this right.
Please.
The main Parkinson's symptom that is helped by DBS is tremor.
So it does anything that is levodopa responsive. So it tends to be the symptoms of slowness, stiffness, tremor, and sometimes walking, sometimes a certain kind of slow walk. Now, there are some exceptions. With tremor, there's actually certain types of tremor that are not responsive to Sinemet, but still could be responsive to the DBS. But the general rule would be is that anything that is better with the levodopa, it will be better with the DBS. Now, one thing to know is that the effects of the DBS makes your on time longer. It doesn't necessarily make it better, but it does make it longer. So that's a very important distinction to know the difference. So yes, it is tremor, but also stiffness and slowness as well. Go right, the gentleman on the right.
Yeah, these electrodes they put in the brain, the picture showed a field going away from the electrode.
Yeah.
What do those fields consist of? It's essentially a saltwater environment in your brain, right? So how can
Are you an engineer?
Well, it's basically current. So the question was with our picture up on our slides depicting kind of the field of stimulation that is created with the electrode, what exactly is that field? It's basically just electricity around that area, around that electrode. So in terms of, if you're asking, if it's salt water
or brain tissue.
Yeah, or brain
tissue that we're stimulating.
How do you sustain an electric field in a saline environment?
Well, the electric field is, you mean from the battery or?
At the point of the electrode.
Yeah, I'm not quite sure. Yeah, I don't know how to answer that question, actually. It's a good question. And it's something that I can maybe ask some of the engineers. Yeah.
Oh yes, the gentleman in the middle.
Does this have some mechanical side effect? Like, for example, if somebody with this falls by accident, trips and falls, or it passes by, I don't know, some electrical magnetic field, high voltage or something?
It's a very good question. So the question was are there any mechanical things you have to avoid because is there a way to damage the wire? So and electrical stuff. So structural, physical, mechanical, and Electrical, okay. So in general, one, in terms of physical or mechanical, the wires are very much anchored on. It will be very, very difficult for you to fall and break it. You would have to basically almost take a knife or something and try to cut it purposely. So in terms of mechanical falls, no. In terms of things that we do restrict, one, so if you're a scuba diver, there's actually a certain depth, I believe is 100 feet. It's actually not very far, but there's a certain depth that actually that much pressure could destroy it. Yeah, I know. Other things, skydiving, if you same idea. So same idea, but having a pressure change. Yeah, exactly. Spelunking, those kind of activities.
If you have Alzheimer's, you don't go scuba diving, right? You get to Hawaii by accident.
If you get to Hawaii by accident?
I'm saying if you have Alzheimer's and go scuba diving, you may end up like you forgot where you're coming from.
Oh yeah, that is true. So the idea, the question was, well, if you have Alzheimer's or dementia, you'll forget, and then they will go scuba diving. In general, if you have actually Alzheimer's, hopefully you didn't get the DBS actually, because that is one of the criteria against it. You should not have significant cognition issue, and that is partly why, is because it does take some, you have to take care of it. You do have to take care of it. Other things that, in terms of mechanical stuff, we do see if there's a patient that has works out a lot and has bigger muscles in the chest area, that is something we don't want too much. Other things, yeah. So yeah, not usually. Now, electrical things and magnet things. So in the past, some of the older batteries actually used to either turn off or become malfunction when they went through those airport security things. So they used to do that, or even through like the shopping, like Ralph's and stuff, and they have that. So they used to actually go crazy with that, but now they don't. So now I don't believe there's any significant interference with electricity or anything like that. I say sometimes with the airport, I just tell my patients at the very least check that it's on when you get to the gate after you go through security, but in general it should be fine. There should be no problems.
You're talking just about the battery. I'm talking about the magnetic field inside, right? So there is some interference from the outside interfering with whatever you're doing there, right? Like if you pass by some electric or magnetic field there.
I don't think it's strong enough to do that. It's like a millimeter. The actual area that we're stimulating is 2 millimeter big. Mm-hmm. It's very small. Yeah. It's very, very precise. And that actually is why we have to do the surgery awake, and that's what Dr. Lising actually specializes as being in the OR and being as precise as possible. Go right ahead and when you're ready.
Me?
Yeah.
So I read something that said that statistically there are more people with essential tremor than with Alzheimer's, and I'm wondering how the mix of your DBS patients has been. Are there more excuse me, not Alzheimer's, but
Parkinson's and ET.
Excuse me, I missed.
No problem. So I think the question is, what is our patient population in terms of the DBS who have essential tremor and who has Parkinson's disease?
That's my question.
No problem. No, it's okay. So in general, you're correct. Essential tremor is more common, but to a point where you need DBS, so that's severe, that number actually is much smaller than the patients who get that severe in Parkinson's disease. So the majority of our patients are Parkinson patients, but they're managed very similarly.
It's kind of an extreme tremor situation that we need.
Exactly. So we're saying it's more of an extreme tremor when you get to ET, as opposed to Parkinson's. You don't have to be that extreme. You can kind of be in the middle. So there's a little bit more Parkinson's disease in the ET, in the surgery world. Go right ahead.
I'd like to ask the people that have had it if they feel comfortable saying if they would have it again.
So the question was if anyone wants to volunteer, of course, if they've had the DBS, if they would do it again. Yeah, sounds good. Yeah, sounds good. Any other questions? I think you had a question.
Yes. If I have difficulties with slowness, how do you determine that I'm an appropriate candidate for DBS?
So the question was, if one has difficulty with slowness, how do we decide if he's an appropriate candidate for DBS? So a part of the evaluation is that on and off testing. So the reason why we do that is we want to see the difference between when you're on your medication and off your medication. Now, DBS in general helps with levodopa responsive symptoms. Now, if your slowness does not get better between the off and on, then the DBS will not make that slowness better. But if it does, then it will keep that on time. Instead of being maybe a 2-hour on time, it would be now a 3 or 4 hour on time. So that's how we know, is through that evaluation.
Thank you.
You're welcome.
I have a question.
Does it help your golf game?
I'm sure it's helped several of my patients' golf games. Yes, it can. It just increases your ability to be less Parkinsonian, so less.
I had a hole in one 2 weeks ago.
Yeah, good. Okay.
Yeah. So the question was whether it helped with certain sports such as golf. I would also agree with Dr. Lising. We have patients who are surfers and all different basketball players and things like that. So not that we can say a specific sport will get better, but your general movement will get better. I'll go right on the left hand. Oh, my left.
How many surgeries are done in a year at Stanford?
So we average at least 2 to 3 surgeries per week. Yeah. Maybe two surgeries per week, and then holidays and that kind of thing. But on average, we have 2 surgeons now, so the volume has actually gone up a lot in the last year to 2 years.
And how long from the minute you start when you start looking at it, going in and getting testing, to after surgery? How long of a span is that?
Yeah, so the question is how long of a span is it from initial evaluation to the surgery, and how long does that process take? So it can vary, but in general, we tell patients it can take up to a few weeks to months. So you come in, you have to get evaluated. If you need some medication optimization, that may take some time. We have you see the neuropsychologist. Sometimes it can be actually very speedy. If you're kind of, if let's say a surgery date opens up and you're already kind of teed up to get the surgery done, some patients may get it done sooner in terms of like someone canceling and you're flexible. So we've had patients get it done, fairly quickly, and then usually it's limited by our wait list. So right now we're kind of having patients scheduled out until the end of May already. So that usually is what depicts how quickly the surgeries occur and how fast that process happens. Yes?
What is there an average age of the patient who does this, and does the age when you do this change the positive outcomes? Like, does that 3 to 5 years become shorter if you're doing this at 76 versus doing it at 60?
Yeah, so the question was, what is the average age that patients tend to get this surgery done, and does age actually affect the outcome of the surgery in terms of the benefit and the efficacy? So the average age usually is I'd say above age 60. Our average age of Parkinson's patients is around 60, 65. We do get younger onset patients that get it done, so it really does vary. In terms of the age, the older the patient is, if that kind of limits the efficacy. So that's part of our selection process. Is we do look to see how the patient, what symptoms will benefit from the DBS and what symptoms they're disabled by, their levodopa responsiveness. So in general, chronologic age, we tend to not look at so much. And patients who've had the disease, it's really just tailored to the patient, because everyone can be, as you may be aware of, Parkinson's can look very different with each patient. So we don't tend to kind of give an overall statement for that. We like to assess the patients individually.
And especially at times, sometimes we can have 90-year-olds that actually act like 50-year-olds, and that's kind of the same idea, is that it really depends on how healthy your brain is, and healthy they are generally. If they have significant heart problems, lung problems, we have to really think about, those could get worse during the surgery time. So that's why it really is a case by case. I think the oldest I've implanted, 92. I think that's my oldest.
Oh, really?
Yeah. So
that's pretty
so it's
good.
not an age thing. It's a person health, overall health, and kind of brain health thing as well. Great.
Are these procedures all covered by Medicare?
Yes. Yeah, for essential tremor, it's covered, and for Parkinson's disease, as well as dystonia.
Dystonia.
Yeah. So those are kind of the other conditions that deep brain stimulation is used for. We focus today on Parkinson's disease, but people with essential tremor and dystonia can also get the surgery.
Yeah, go right ahead.
You mentioned the 2 brain sites that you use for the surgery. How do you decide which brain site to use? And what is the frequency of using each?
Yeah, so the 2 brain sites, the question was, there were 2 brain sites mentioned that we use for Parkinson's disease. And these are the 2 sites that are typically used that are targeted, which are the subthalamic nucleus and the globus pallidus interna. So in terms of how we decide which is used, so there was the co-op study. It's this huge trial done with the VA that looked at efficacy between STN and GPI and basically showed that they were equally effective in treating the motor symptoms of Parkinson's. There was thought that maybe the GPI may be better for people who have cognitive concerns or mood concerns, and that the subthalamic nucleus may be better for tremor, slightly better for tremor, but in general, we choose them equally. Here in our center, the surgeons can implant both, so they can target both, and we typically just tailor that to the patient.
Okay, great. We have time for one more question. Let's go right ahead.
Do you ever have cases where they enter the brain with this probe and they work it around and just flat doesn't work?
You mean in the operating room? So
Yeah, you're going for controlling a tremor or whatever you're controlling, and the procedure is just not having any effect on the patient.
So the question was, do we ever find that we actually go in the operating room, we have a patient, and when we're mapping, we don't get the benefit. It doesn't control the tremor. So in general, when we do stimulate, we try to localize the patient's nucleus correctly, so whether it's the subthalamic nucleus or the GPI. And in general, if the patient does have Parkinson's disease, I haven't had a case where we don't get benefit in some benefit in their symptoms. And here at Stanford, we actually do some objective measurements of their movements. And even though by the human eye we don't really visualize, we can't tell that the movement's improved, with our kinematics we can actually have that objective measure, showing that maybe that they have improved in terms of their speed or their rigidity.
Great.
I think that's it.
Fantastic.
Okay.
Thank you for having us.
Yes, thank you.